Welcome to the Australian Prescriber Podcast. Australian Prescriber, independent, peer-reviewed and free.
I'm Denali Pereira, your host for this episode, and it's a pleasure to be speaking to Jerry Yick today about changing Australian medicine names. Jerry Yick is a policy analyst at the Society of Hospital Pharmacists of Australia. He also currently works as a hospital and community pharmacist in Melbourne. In the June edition of Australian Prescriber, Jerry explains how the Therapeutic Goods Administration is changing the names of approximately 200 medicines. Jerry, welcome to the program.
Thank you very much, Denali.
So the main aim of these changes is to harmonise Australian medicine names with international names. Can you tell us a bit more about these changes and how they ultimately improve medication safety?
And the whole idea of this was to harmonise what's known as the Australian Approved Name, or the AAN, with the international names, or known as the International Non-Proprietary Name, to reduce the confusion and inconsistency with medicines naming. And the whole idea of this was to ultimately improve medication safety and the quality of medicines. We know that in a country like Australia, there are a lot of health practitioners who travel internationally, a lot of patients travel internationally, and also there's a high level of practitioners from overseas that come to Australia. So there can be situations that arise where what you know as a certain medicine name may be different to what you've known it as your entire life of practicing and what you've learned at university. And so when you're put into a different setting altogether, there might potentiate some confusion, can lead to prescribing errors and ultimately medication errors as well.
Right. Okay. So sort of bringing it in line with everyone else.
Yeah, pretty much.
Okay, and so most of the medicines will have a 4-year transitional arrangement, is my understanding. How is it decided which medicines will require a 7-year transition and why?
Yeah, so some medicines require 7-year transition requirements, and these 7-year transition requirements mean that they need to be undergo dual labeling. So on the medicine label and also on the dispensing label, it should show both names. So just for example, for furosemide, what it'll change to is furosemide. So what should appear now on medicine labels is furosemide, and then afterwards in brackets, furosemide. And all medicine labels for furosemide should show both those names for the next 7 years until 2023. And then from 2023, only furosemide should be used, and furosemide will never be used ever again. Now, how it was decided that these medicines would require dual labeling, because the TJs determined that they just carry more significant risk and more clinical significance that require dual labeling. And I think the reason for this is that the new name is just that much a little bit more different that could potentiate some confusion and maybe misconstrued as another medication altogether. So for example, another medicine that requires dual labeling is dithiopin. Dithiopin will now be known as dosulipin.
Right.
For another example is lignocaine is lidocaine, or glycopyrrolate and glycopyrronium. So there's just enough variation in those letters that it may be misconstrued as a new medicine. And we know, when you're studying chemistry and biology, a few letters can actually mean something else altogether.
Yeah.
So that's why they've used dual labeling for these ones, but they haven't for, say, amoxicillin and ceflexin that have just literally 1 or 2 letters changed. That one, it's the chances of having amoxicillin and ceflexin misconstrued as something else is very, very low.
Right. So the medicines that will have the 4-year transition won't have the dual labelling, is that correct?
That's right there.
Yeah. Okay. So can you tell us a bit more about why adrenaline and noradrenaline will be treated so differently to all other medicines?
Yeah. So adrenaline and noradrenaline, just to be clear, these they are not the international non-proprietary name. The INN for these medicines is epinephrine and norepinephrine. Now, adrenaline and noradrenaline have received special treatment because the naming is so inherent and so fixed in our systems and in our healthcare environment. And due to their therapeutic use in anaphylaxis and life-threatening situations, the risk in changing these names completely is too great in terms of safe prescribing, dispensing, and administration, especially where time is very, very critical.
Yes.
So from now on, adrenaline and noradrenaline will always be known as will always be known dually as adrenaline epinephrine and noradrenaline norepinephrine. So it's the Australian approved name first, and then the INN in parentheses afterwards.
Right. Okay. That sounds fair enough. Some medicine names will not change despite having common alternatives used overseas. Can you tell us a bit more about those?
I think the reason why the medicine names for those haven't changed despite common uses overseas is because we are already currently using the INN, and therefore there's no reason to change that. I think when people say they're commonly used overseas, it's probably because in the American context, where a lot of research does come out. So, for an example, is paracetamol, which is what we know as in Australia, that already is the INN, whereas in America they know that as acetaminophen.
Yeah. Okay.
For what we know as salbutamol here, which is used in your asthma relievers, that's known as albuterol in America. So, but because Australia already uses INN, we're not changing that. And the onus is on the other countries that don't use the INN to change their practices if they do think that there is an inherent risk.
Obviously, health professionals have to lead the way with communicating changes to patients. What resources have been developed to help us do that?
Therapeutic Goods Administration has come up with some resources both for consumers, pharmacists and doctors that go through that provide some leaflets and handouts you can put in your pharmacy or the GP practice that sort of let consumers know that there may have been a change to your medicine name and that you need to speak to your doctor and or your pharmacist to be across them. Similarly, with the Australian Government Department of Health, they've also come out with a leaflet that explains these changes as well. What was just some examples of what was a previous active name and what the updated active name now is.
Okay, great. And I think there is a link in your article online to some of those resources as well.
Yeah, there is. Yeah.
Yeah, that's excellent. So speaking of resources, I imagine this will be a huge project to update medicine information resources. Do you know when and how these changes will appear in references like Australian Medicine's Handbook?
So it is quite a massive change that all these resources will have to undertake, and that's sort of why they've been given a 4-year transition period. I know with the Australian Medicine's Handbook, currently the monograph is still directed to the current Australian approved name, and it hasn't transitioned over to what the new name will be. However, if you look on the index for the new name, it will say see old name, and then you look at the old name again, and then you're directed to the page. So, for example, if you search up furosemide, FUR in AMH, it'll tell you to go look at frusemide instead. Same for something as quite different. So trimeprazine is going to change to alimemazine, which is quite a massive change in spelling. So if you look at the new spelling, the new name, which is alimemazine, the AMH will tell you to look at trimeprazine.
Right. Okay. So it's the index has got both of them at the moment, but the monographs are yet to change.
That's right. And the other resources that will need to change are things like your therapeutic guidelines, MIMS, any clinical guidelines that are used in local hospitals. Another thing that needs to change would be as hospitals make the move towards using electronic medical records and electronic health records, the data sets that they're loaded up with need to reflect the new names as well.
So it is a big project then.
Yeah.
So I think people will probably have to get used to looking up both names and some resources until it's completely changed over.
That's right.
Yeah. Okay, and so you also mentioned in your article that these changes were completed in the UK and New Zealand already, which is nice to have someone else as a guinea pig for big changes like this. Do you know if there were any incidents that occurred in those countries, and if so, how we will mitigate the risk of those incidents occurring here?
Yeah, I try to do a literature search as to if there were any medication errors or adverse events that were attributed to when they decided to harmonise their medicine names. And unfortunately, I wasn't able to find much data on this. But I wouldn't say that's because it doesn't occur. I think it might be because that medicine adverse events are multifactorial, and if they did occur, they may not have been entirely attributed to a confusion in name change. It might be, some other factor. I did come across an interesting anecdote in America where, I'm not sure if it was America, but it was another country where they knew paracetamol as acetaminophen, and someone who had overdosed on paracetamol had ordered acetaminophen off the internet, and then when they were while they were in quite a bad state and trying to communicate that to the nurses and the doctors in the emergency department, they were saying one drug name, but they just weren't understanding what it was, and so the paracetamol overdose wasn't detected until quite some time later. Yeah.
That's unfortunately all the time we've got for this episode. Thanks for joining us today, Jerry.
Thanks, Danelli.
Jerry Yick's full article is available online at nps.org.au/Australian Prescriber. Unlike our whole journal, it's free. Subscribe to get the latest Australian Prescriber delivered straight to your email inbox, and follow us on Twitter at AusPrescriber to get the latest updates. The views of the hosts and guests on the podcast are their own and may not represent Australian Prescriber or NPS Medicine Wise. I'm Danelli Pereira, and thanks for joining us on the Australian Prescriber podcast.